Hello, and welcome to the HSJ Health Check Podcast, where each week we explain and debate the most important news issues right now in NHS policy and leadership. I'm Annabelle Collins, and this week I'm joined by Deputy Editor Dave West, Bureau Chief Ben Clover, and Senior Correspondent Sharon Brennan. This week we will again be focusing the Health Check podcast on our now free-to-read coronavirus coverage, this week focusing on three key themes of procurement, workforce, and demand. Over the last few days, hospital chiefs have spoken candidly about the availability of ventilators, with concern that demand for ventilated beds will outstrip what they have as the number of patients seriously ill starts to ramp up. So first of all, Ben, I'm hoping that you'd be able to expand a little bit on some of the concerns we've been hearing around supply of ventilators.
Yes, so ventilators are one of the very biggest issues facing the service at the moment is when you get people who are seriously ill, who really need the support. Ventilators are literally a life and death issue. Now we've got some of the national numbers about supply versus demand, and last week when I spoke to people in hospitals, they were very, very worried that this week would see a terrible mismatch between people who needed ventilators and the amount that they had, and that was going to basically lead to a lot of avoidable deaths. Speaking this morning to people, and this is all in London, because London is still the epicenter. Growth elsewhere, but it's still the epicenter for admissions and hospitalizations. The quote this morning I got from someone was supply is staying just ahead of demand so far. So these things have started arriving. Like, I spoke to one trust that had managed to quadruple its number of ITU beds. The ventilators were starting to arrive at kind of another really quite large trust. That it was staying just ahead of demand. That's still very vulnerable to spikes, still very vulnerable to delays, but the sort of nightmarish scenario people were concerned about just this time last week seems not to have arrived just yet. That's not to say it won't be here in another week if we get a real spike. And the kind of the picture on supply is still very confused. Like, there's still, although we've had spokesmen say the system is not at capacity, that's a real theme in official communications at the moment, is saying, the system's not at capacity, there is enough PPE. That, as always with the NHS, and most particularly now, it's the variability. So, all right, there might be enough capacity nationally, notionally, but if you have a mismatch in one particular area, that really is going to see a spike in avoidable deaths.
I think the regional dimensions of the spread of the virus in the UK and in other countries, but from our point of view for the NHS and in the UK, the regional dimension of it and how that pans out is going to be really crucial, because it does. We published a piece that I wrote in the week about how this is going to pan out in other parts of the UK beyond the big three cities, because there's been quite a lot of focus on the new Nightingale Hospital in London, and the peak, as you say, in terms of cases and admissions, absolutely is in at the moment in London. And there's a focus on creating the Nightingale Hospital. Lots of imagery in the news about that hospital being fitted out, and there's also similar facilities being created in Manchester and Birmingham. But lots of people beyond that, out in the kind of counties and the coastal areas where hospitals do tend to be weaker and populations tend to be older, there are generally speaking many fewer cases. But if and when the wave does come, they're in a pretty vulnerable position, and they don't yet have a sort of a Nightingale style plan from the centre about how to deal with that demand. They're also they're asking for ventilators, and they're not at the front of the queue, understandably, because there's not a pressing demand there, but they are getting very anxious about when and whether they will actually arrive and what sort of capacity they'll be able to create. Now, if the characteristics of the virus is kind of like a wave whereby it rises in London and then spreads out, but by the time it gets to East Yorkshire, actually there's virtually no demand in London, then that's kind of might be okay, because you can kind of rush all the ventilators and things. As difficult as that is, you can rush the capacity or move patients around, even in some cases to where the need is. But if it's kind of, this is more of a rising tide with a wave at the top of it, then when it gets to East Yorkshire and et cetera, Cornwall, then there's still a massive demand in London. Well, then you're not going to be able to take the ventilators out of London, because there's still going to be excessive demand and patients very much in need and on them in London. And that's I think where some of the concerns coming out beyond the big cities.
Yeah, it's going to be a very scary logistical job doing that transfer, if, like you say, the transfer is possible. We're quite lucky in some ways in that Britain's actually a relatively small country for its population. So, but what we've seen in France is actually like military helicopters having to move some of this equipment in a real hurry to other bits of the country. Kind of, there's also sort of rumours that the Navy's hospital ship with its 15 critical care beds might actually could get deployed potentially to places like, coastal areas that are going to need the support. But I mean, kind of ventilators, terrifying issue though that is one of three fronts that are receiving a lot of attention on procurement. I'm not proposing to talk about testing too much, because that's that's got more of an HR angle. But the other thing that's received a lot of attention is PPE. And again, this is another thing where a lot of the official communications have said there is enough PPE, we're trying to get more, no regional details. Now there's been confusion obviously over whether we should be adhering to a WHO standard or the NHS's own standard. But whatever the rights and wrongs of that and the communications issues around it, the geographical differences are really very marked. And the big workforce institutions keep raising concerns about this. So again, this morning I've spoken to a chief exec of a community provider who says, like, as of today, he's going to have to make very serious cuts in the amount of home visits his staff can do because of a lack of PPE. So kind of the regionalised bit, and saying not only had his organisation been missed off sort of emergency resupplies, but also kind of the regular drops. So it's really unfortunate that the quite fragmented, although very hard-working world of NHS procurement beforehand has led to these real disparities, which again I think we're only just starting to see some of the consequences and fallout from that. I mean, it was reported earlier this week by us that PPE has been brought out. It's been separated out from the rest of NHS procurement and given to a company called Clipper. How they do remains to be seen. But yeah, that ventilators and PPE are still huge ongoing issues for the service.
And I think that's something there, Ben, that there's been quite a lot of focus in the news about acute trusts, the PPE they're getting, and obviously the ventilators that they need. We are actually seeing quite a hit in the community and in community health and GP health on this kind of thing. So I've been speaking to GPs who've said to me that they do not understand the gap in understanding between the national like NHS England coming out saying, there will be PPE is going out, and what's happening on the ground, which is that they've not got anything. And they're still, one told me they're going in to do home visits with like a wet tissue over their mouth, and they're worried that they are the ones spreading coronavirus. And I think that also points to something about some of the vulnerable people in the community, those that have been told to shield for 12 weeks, and those in nursing and care homes. They're actually getting a lot of the side effects and the knock-on effects of COVID is hitting them. So not only are, we're now hearing from Ben that some community health visits may not be possible because of PPE, we're also now hearing that GPs are proactively going out to nursing homes and care homes, and some people over 80, and talking to them about signing do not resuscitate forms, because they're being told that they would unlikely get an ICU bed. So as much as we talk about ventilator capacity in acute, it is already on those vulnerable people living in the community who are being told that because there isn't enough capacity in the ICU, they probably wouldn't be eligible for ventilation, and therefore, how would they like their last days to be if they did get coronavirus. So I think a lot of this is spreading out much wider than just procurement within trusts and hospitals, as important as that is.
Yeah, the fact the anticipation of a lack of intensive care is kind of sending waves around as well. And I think that just to come back to that logistical issue, we don't want to sort of be kind of backward looking, and there'll be lots of backward looking kind of reviews and inquiries when the peak has passed. But the few days both on PPE and staff testing that we'll probably move to talk on a little bit more later, that kind of it clicking at the centre that they're moving from a relatively small process. Clearly NHS logistics is massive at the best of times, but on PPE you're moving from something that was relatively small to just an absolutely massive logistical operation. And similarly on testing didn't seem to happen very quickly, and that's resulted in this huge logistical process, and then huge controversy around it not moving quickly enough, among other factors.
And I think we've seen as well kind of trusts taking matters into their own hands. And that story we published over the weekend, in which I think it was Leicester and Northampton have kind of implemented their own PPE kind of measures, because do you think that sends kind of a message about kind of a lack of confidence in the kind of the PHE policy?
I mean, I think like trusts always there's been quite a long history of trusts taking responsibility themselves and sort of seeking to do things outside. Like, it was always one of the most decentralized systems, procurement in the NHS, and in lots of cases trusts would do a great job of it. In other cases they get kind of ripped off, and that's one of the things that the Carter Review looked at explicitly. So I mean, I was speaking to a lawyer this morning about whether there's going to be potentially a whole kind of swathe of litigation afterwards. There's like the huge mess of different contracts gets swept up into the centre.
Well, your point about in terms of the way it's affecting staff and leaders, that it's absolutely hugely anguishing and invidious. And there's comments about leaders not wanting to have to go and face their staff, managers not wanting to have to go and face their staff and explain the situation as it actually is, which is potentially that there is no kind of rational justification for some of the actions that they're probably going to have to take in providing care in circumstances without the equipment that they feel they need, in the circumstances where they probably will get infected in some cases. And you're asking people to do sort of I know all the military analogies are being overplayed, but you're asking people to do things that are just not really very rational, but they do need to be asked to do them. And the case we reported yesterday was in Southend, I think, where doctors had written and said we are going to scale back A&E care if we can't get the equipment that we believe is needed. And there's plenty of accounts of surgeons in particular saying I think they're not going to work in certain circumstances without equipment. And it's unfortunately might come back to some of this sort of kind of really difficult regulatory and ethical sort of crossover, where we're saying, okay, there's an ethical question about when you about the fact that you will be protected as a doctor if you do things like in terms of admissions to ICU and take greater risks in care than you normally would. But also there's an ethical question for clinicians about like the actual need to treat people in some circumstances, even though for yourself personally it might not be a rational thing to do. I suspect those questions are going to keep coming up.
Yeah, I mean, you might be protected in a regulatory sense, but you won't be protected in a kind of immunological sense. Like we've already had I think the tally, and I'm sorry if I'm out of date on this, I think the tally of NHS staff who've died from this now stands at 6. And kind of it's very clear, speaking to the trusts that were employing them when they appear to have picked up infections, that there is no set procedure that's come down from the centre on notifying other staff or patients they may have come into contact with. Some places are writing to everyone, some places don't seem to be doing that. There is not a clear procedure on that, and a lot of the damage is sort of already in the post on that. Kind of even if it were to be sorted tomorrow, kind of if everyone was to get their PPE tomorrow to their own satisfaction, there's still, it looks like, a good 2 weeks worth of potential infections to come down the line from just from, so to take the case from Nelft, that was on the 14th of March. So it's not clear how long that individual was infectious for before, and how many people he worked with. Kind of trusts probably need support with the procedure for this, let alone with actually getting the PPE. That's not something that we've seen very clearly. And then maybe the testing of staff will help with that. But you couldn't really, by any fair measure, say that the NHS was on top of this so far. I wouldn't have said.
Similarly, Ben, I've been speaking to a leader of a PCN saying that the angst and the anxiety around GPs without PPE visiting people who are potentially have coronavirus is overwhelming. There's, these people are normally very calm and capable in their job, and yet you're right, we are asking people to do certain procedures that they don't feel comfortable with, but without doing that, these people, the patients that they look after, wouldn't get the care and treatment that they need. So you're right, it's a very it's kind of shocking. We've lost 6 people already when we're only 2-3 weeks into the crisis of the rise of the pandemic.
Annabelle, on the broader staffing and workforce question, which is one of the huge dimensions of the NHS response, can you talk to us as workforce senior correspondent a bit about some of the other staffing issues? We published a news story this morning that you wrote about that.
I think staff sickness absence is obviously a huge concern. I mean, not so much in the trusts outside of London at the moment. As we've said, they're kind of waiting for the surge to hit, but very much in London. I think we've seen some kind of quite high figures reported in the media. I think it was the Royal College of Physicians, which said 25% of doctors were off sick. Was that right? I mean, that seems very high. But I think there is confusion among staff as to what they should do when it particularly comes to self-isolation. And so that's kind of relating to the story we published today. And I know that trade unions are meeting jointly about this today, actually, as they are very concerned about how kind of staff are being treated by occupational health. I think there's a lot of variety around the country and how and what staff are being told to do. So the particular instance we reported, staff were told that they were fit to work, even though they'd reported a family member had COVID symptoms, which is obviously very concerning. The trust has kind of responded and said they're clear that staff. Again, I think that's quite ambiguous. Do you preemptively book your stay in a hotel in case anyone in your household falls ill, or is that kind of recovery? Yeah. It's all a bit ambiguous at the moment, and kind of when talking to staff out there, people are quite confused about what they should be doing. And I think often in the NHS there's this feeling of duty, and that people have kind of said to me, well, I'm worth more in the hospital than I am staying at home. So for them, it's quite a clear decision.
Yeah, people are sort of using a bit of ambiguity has been created, and employers, in some cases, will use that to bring people into work when they otherwise wouldn't be. And you can see it from both sides. If we're talking about there's a chief exec saying they've got sort of 10-15% of their staff off or more, it's going to become really, really difficult to run services. And of course, if the peak of staff absence comes and sort of collides as the peak of coronavirus demand on the hospitals arrives, then that will be the more problematic peak in a sense than because they won't be able to provide the services full stop.
No, absolutely. And I think that also from kind of speaking to kind of HR and also clinicians working in trusts, the kind of the rotas have been designed in quite a particular way to kind of ensure the only people in the hospital are those kind of essential staff members, and kind of giving people kind of multiple days off as well to kind of, I suppose, try and deal with kind of fatigue and burnout, because that is obviously going to be a massive issue, as we've already talked about, kind of the letter from the regulators. And again, we've seen this week the junior doctors, 2016 contractors, essentially been temporarily ripped up, in that doctors can be, they're not going to be sticking to the, a compliant rota or the kind of usual hours that they work during a week. And I think that's going to have massive impact on, obviously kind of resilience, but kind of also mental well-being as well.
Absolutely.
I think that also plays into what will happen once this is over. And I know at the moment when you're in the midst of the pandemic, it's hard to look forward, but I think there will be something to be said about how staff can carry on in a normal capacity after this is over without needing extra time off or extra support, because you can push through on adrenaline and duty when you're in the middle of a crisis. But once it's over, it'll be interesting to see the impact on staff, not only morale, but numbers, sickness, ability to work, etc.
Absolutely. People who've taken maybe another year out of training, because, you know, I think they'll be going back into a system that still won't have any slack. So a lot of these departments I don't think there's necessarily going to be the kind of the breathing space that people will need, and you know, the additional staff that have come in, the retired staff, the students aren't permanent. So yeah,
so it seems to me you sort of need a kind of major recovery plan. We were kind of talking about this a bit on Tuesday, was it, Sharon, when we were on a sort of webinar for our HSJ Intelligence tool, and the kind of a recovery plan for the service itself and for its staff, and a kind of a recovery plan for all the increasing evidence we're seeing of the service of the knock-on effect on other services and the harm that will do to health and healthcare, which is sort of put aside or deprioritised, or for various reasons now not taking place during the COVID-19 outbreak. And you've done a bit about this, Sharon. I don't know if
yeah, so one of the things we were looking at was the impact on cancer care. There was guidance that was out saying that patients would have to be prioritised for cancer surgery, radiotherapy and chemotherapy if there wasn't the capacity to offer it to everyone due to staff illness or capacity within the hospital itself. And at the time they were saying that, you know, it looked very much so that people needing palliative care, so chemotherapy that would help them to extend their life by a few months or to alleviate pain or other symptoms that come with end-of-life cancer, would not be receiving that chemotherapy or radiotherapy if there was an issue with delivering it to everyone. And since then, we have now seen that they're talking about trying to set up cancer hubs, which are free, which are COVID-free, which may well involve quite a lot of independent sector work. Because they are very much those day-to-day chemotherapy sessions can continue to be done if there's capacity, but also if they're done off-site from acute trust, even with coronavirus, with the view that if you were having your chemotherapy, you would therefore not catch it. And I think some of that is in response to the fact that, you know, how do you tell families that you thought you would have another year with your partner and you can't because the coronavirus has kind of hit capacity. And I think one of the things I was talking about with my colleague Rebecca was like, who makes these decisions? So she's been hearing from a GP who has a cancer patient who was told that her surgery is routine and not an emergency. The GP disagrees, but you know, who is the person? How do you know that these ethical decisions are being made correctly? And I think when you talk about the hit for when we try and get back to a recovery plan, there is a big concern about the 2-week wait list for cancer referrals. So at the moment there's been a slight change saying that, you know, these referrals should still happen, but if an acute trust does not have the capacity for the consultant to see people who have gone to their GP and said that they have concerns, they have cancer, that, you know, the acute trust can delay or push back on some of these. And there is an additional addendum saying, well, there should be a safety net for the people that are most at risk of actually having cancer. But again, who decides that of the 2-week wait referrals, which ones are most at risk of getting cancer and which ones are not? So not only is it an issue, therefore, about how do you pick up the capacity afterwards to push through some of these referrals that were not looked at, how do you know that you're not causing real harm to people that might well have benefited from chemotherapy much earlier? And not only are we seeing that in cancer, we're seeing it in stroke. I mean, Dave, you picked this up earlier. It appears that A&E attendance have dropped by about a third in 2 weeks.
Yeah, I think we might see today even further drop in attendances, because some of which, you know, lots of people have leapt on to say reflection of some of the kind of silver lining sort of transformation stuff about people accessing, you know, perhaps accessing what is effectively should be primary care rather than going to A&E departments. But you know, it's impossible to think that some of that demand is not actually genuine needs that are not being met. And seeing stroke attendances and admissions fall is clearly a sign of that, and I think we're starting to see other evidence of it as well.
Yeah, we've seen tweets saying that stroke wards are empty, and that the concern now is that people are staying at home because they've been told to, and not actually seeking the help that they need. So again, that might be something that you pick up later down the line about who are these missing people, where have they gone, what conditions did they have, what were they not being treated for.
I don't know whether, kind of linking to that, I don't know whether you've kind of had the same things, but exec who was saying they're looking at a half-empty hospital, and they said they'd usually see kind of hundreds of major cases in A&E, but in one day they'd seen 30, and they were kind of saying how worried they were that we're going to see kind of, obviously not kind of in a sharp peak as with coronavirus, but kind of a surge of patients with quite kind of serious health problems who would have otherwise attended hospital and who haven't, and who've kind of been deteriorating at home, and kind of what impact that's going to have on the system a bit further down the line. I don't know whether any of you have any thoughts on that, or whether you'd had similar.
Yeah, exactly. Concern. I mean, some of the people, they should perhaps never have gone to A&E and they'll be fine. Some proportion of the people, we don't know what, will have an acute episode as they deteriorate further, probably, or things that similar things to that. So could rebound over time, or even in a sort of cliff edge way, which would be really worrying if we're still talking about a couple of weeks' time and we're still in the midst of a coronavirus surge. So some of that demand will come back, and similarly, masses of discharges being made from hospital. That's great if it's happening now because just the funding barrier has been removed, or because a more responsive service has been set up to help people get out of hospital, or because their family have come to take them. But not so great if it's because they've been discharged into circumstances where they're not actually really being cared for properly.
And I think this goes full circle around to what Ben was talking about at the very start of the podcast, that as yet, the test on community health capacity has not happened. We haven't yet had these mass discharges coming out of acute. But when they do, I've heard one person tell me already that they think it's going to blow up. They think community health care is going to blow up because they have, they don't have any extra resource. They don't have the staff to be coming in dealing with not only an increase in people going into community care, but a much, much higher complexity rate. So we're talking about people going home on oxygen, going home on very strong intravenous antibiotics that have to be administered at home, going home ambulatory. This is all in an NHS England document. Going home with ambulatory needs for health for heart conditions. And not only does this need a patient able to feel that they can cope at home, although they may not be given the choice, it does need a significant response from the community health sector, and whether or not they have the capacity to do so. I think Annabelle feeds into that point about what will happen to these people who are left at home deteriorating, and will there be a big hit on hospitals in a few months down the line where people just were not getting the care that they needed?
Perhaps it's an argument for it's I suppose we're slightly getting ahead of ourselves in terms of the peak hasn't happened yet, but you kind of need a kind of a complex sort of recovery and transformation plan where the resources put in, because all that stuff is kind of brilliant if it's, as you say, resourced properly and for the right people and so on. But you need the resource, the Chancellor's money, which has been flowing, to kind of keep flowing in order to make sure all that stuff sort of happened in a safe way, and that it's transitions to a kind of a sustainable basis for people being cared for in the community, instead of a very fragile basis. But was it? Did I skip something there, Ben? You say that you think that hospital discharges from hospital haven't really happened yet in earnest.
No. I think from what I'm told, in plenty of places they have sped up the programs of discharge.
Yes.
And in some places, some people I've spoken to said that's gone pretty well, like in London, which seems like quite well resourced compared to some areas. They're on top of that. In other areas, people have told me the opposite, that it's come and they're not as well prepared for it. And this is before, like we say, the other PPE issues. I mean, it's important to remember, kind of, even if we're seeing a reduction, even if we've cancelled elective work for 3 months, even if we've seen a 1/3 reduction in A&E attendances, which are all going to have their own problems anyway, the system was being run exceptionally hot for an exceptionally long time. Anyway, the system is being run with 100,000 vacancies, kind of. So getting some people back from retirement, getting some students in early, these are stopgaps which you're going to be applying to a surge, which which was dealing with a significant shortfall in staff anyway. So yeah, I think like the point you've been making, Dave, about the recovery plan is going to have to be pretty significant not to see some kind of perfect storm horror stories in maybe 2 to 3 months' time, when all those people who've been discharged too early come back in, when all the people who didn't attend A&E when they should have done out of fear of the coronavirus suddenly do have to come in.
Turn the XL into a hospital permanently and keep the broom in.
Well, it's been kind of striking all the different places that have had to be earmarked for extra ICU capacity, which the NHS has spent the last 15 years trying and largely failing to close beds. Kind of Northwest London needed was one of the places in London that had the least problem with having to scale up its capacity. And that's because for ages people have been saying it's an overbedded health system. We need to take 500 beds out of it. It's ironically the places that have been least forward-looking from the world of the last 15 years that have more beds there. I mean, you've got staff for them, but it means you've got more beds.
Yeah, I see. I mean, critical care hasn't reduced in the same way that general and acute beds have over the last 10 years. But
often it is literally the beds that you need, as well as something to plug oxygen in and the people to staff it.
I see. Yeah.
We've obviously seen amendments on the ratios of people as well, and kind of bringing in less specialist staff to support them. It's kind of a completely new way of working for so many people.
Yeah, throwing people into difficult circumstances. Yeah.
And we did say that we'd briefly talk about testing. We have a couple of minutes left. I don't know whether that's enough for just a few quick thoughts on kind of an update on the situation as it stands.
So, I mean, we touched on it already to the extent that staff testing for coronavirus is been a huge debate and subject of controversy over the last day or two, because and the real pressure being that if too many staff in the NHS or care services and general practice are off sick, then it will be be even less ready to have the capacity to meet the demand. And there's been a huge furore because the government and officials keep promising they're going to ramp up staff testing each day, and then it will be available to health and care staff, and each day, over a few days now in this kind of constant 24-hour news cycle, each day they're failing to achieve that and to achieve much greater numbers. Although yesterday there was an uptick in the number of lab test results delivered. From talking to people involved in this, I think it's been an absolute logistical nightmare. I think the government has tried to sort of point the finger at the NHS a bit and say, well, why are they telling us they can do more tests and they haven't been able to? The NHS has said, well, we've only just had permission on Sunday to allocate these tests to staff, and then on yesterday to completely remove any cap on the number of tests which can be given to staff. But in reality, I think there's huge logistical and kind of timing issues and procurement issues about the sort of reagent, and it's just a massive logistical conundrum which wasn't gripped quickly enough, in various, whether in the NHS or in government, which has caused this issue. And I'm sure will be looked back across the net at the moment. They're saying toward mid to end of April they'll have a good capacity, and can only hope that doesn't come too late to be of great help to the NHS and to people who are needing it.
Thanks, Dave. And I think after that, we're going to have to wrap it all up for today. But thank you all so much for joining me. And just a reminder to listeners, the HSJ Health Check is available each week on the hsj.co.uk website and across all main podcast channels. Please do subscribe and share and get in touch if there's anything that you think we should be talking about. Thanks so much for listening. Bye.